Yes. Hello, everybody. We're going to start in just a minute or two, letting more people join. We have a lot of people that have already joined, but we'll just give it another 30 seconds or a minute before we start. All right. All right. Well, we've got a lot of people on. So why don't we get started? Hello, everybody. My name is Andrew Spiegel. And for those that don't know me, I'm the board chair of the World Patients Alliance. Really pleased that everybody is here today to gain more information from our webinar series. And this one will be about understanding and managing pain. And we know that pain runs across all diseases for the most part. And so we thought this would be a really important topic to cover. And we happen to have Penny Cohen on our board of directors, who has many decades of experience running a pain organization. So she'll be running this webinar. Really happy to have Penny running this. So let's go to the next slide. Next slide. You already know me. So a little bit about us. We are an umbrella organization, the world's largest umbrella organization working across all diseases. We feel that patients need to have an active role in all stages of healthcare, and that's why we created this organization, and we're governed by the principles that are set out on our website. Next slide. We have now actually over 600 organizations. We've had a lot of applications come in recently. So there's more than 600 member organizations from 130 countries. And you can see that they're pretty well geographically distributed, with 144 in Europe, 136 in the Americas, 173 in Africa, 119 in Asia, and 16 in Australia. Next slide. Today we're going to talk about pain. We're going to start with Robert Edwards, clinical psychologist and pain management center at Brigham and Women's Hospital, Harvard Medical School. We're going to hear from Penny Cohen, who, as I mentioned, ran the American Chronic Pain Association for decades. We're going to hear from our other board member, Regina Kamaga, who's going to talk about living with pain. And Regina is the executive director of Chain Network in Uganda. And then Penny will moderate the discussion. So with that, why don't I turn it, next slide, why don't I turn it right over to Penny.
Oh, well, hang on, next slide. Okay,
Robert,
so.
Go ahead. You introduce Robert.
Oh, okay. All right, so Dr. Edwards is a licensed clinical psychologist at Brigham and Young Hospital affiliated with Harvard Medical School. He is somebody that I have known for a long time. He is amazing in the field of pain. I know he's been involved in so many different events and committees that I've also served on. He is a passionate person when it comes to helping people live with pain. So with no further ado, I'd like to present you Dr. Robert Edwards. Sorry.
Thanks so much, Penny. Thanks, Andrew, for that wonderful introduction. And thanks very much to the World Patients Alliance as well. It's a fantastic organization, and it's a real pleasure to be a part of this webinar. So good morning, good afternoon, good evening, maybe good night to everyone. I understand folks are joining from probably just about every time zone. So I'll have the pleasure of doing a brief overview of pain, what it is, how it impacts people, some of our current understandings of pain and pain management. As Penny mentioned, I'm a pain psychologist based in Boston on the East Coast of the US. I work in the Brigham and Women's Hospital Department of Anesthesiology, and our research group concentrates on things like understanding biopsychosocial aspects of living with chronic pain, and we study various treatments for chronic pain as well that I'll talk some about. Next slide, please. As many of you know, pain has been defined in a number of ways. The International Association for the Study of Pain defines it as an unpleasant sensory and emotional experience. If you could click next slide, I'll apologize in advance. I have a number of animations here, so you'll hear me say next slide quite often. I'll just emphasize early on that pain is a subjective, personal experience. There are no formal objective markers of pain, and our gold standard for pain assessment is an individual self-report of her or his or their individual sensory and emotional experience. Next slide, please. Acute pain is actually a fairly adaptive and helpful sensation, much like our other sensory modalities, vision, hearing, etc. Part of the reason we know this is there are some individuals who are born with an inability to feel pain, congenital insensitivity to pain, and it's actually a real challenge to not be able to feel pain at all. You can see some of the life expectancy data for those folks there. So it's a helpful sensation in some respects, but next slide, please. When it comes to pain becoming chronic, and if you don't mind, if you could advance one more, when pain becomes persistent, chronic, lasting, when it doesn't go away, that's when it becomes less adaptive and much more adversely impactful. And so just in the US, there are 50 to 100 million individuals who are suffering from a variety of chronic pain conditions, from arthritis to back pain to headache. And pain impacts more or less every aspect of an individual's life, from nighttime sleep to daytime work and social activities. And it's for those reasons that chronic pain is essentially the leading cause of disability around the world and a leading contributor to many adverse outcomes, such as suicide, when pain becomes chronic and challenging to treat. Next slide, please. The healthcare providers and clinical researchers who work on pain in general subscribe to the biopsychosocial model of pain, which indicates that a number of different factors can impact an individual's pain experience. These can be social, psychological, environmental factors. You can see some of them listed there. And if you don't mind advancing a few more clicks, you'll see that pain experiences can be very individualized. And I'll be talking a bit about some of these biopsychosocial factors that we know can impact the pain experience for individuals and that can serve as the targets for certain treatments that can be quite beneficial for people living with chronic pain conditions. Next slide, please. One thing that is often minimally related to the experience of chronic pain are things like physical findings based on imaging, X-rays, MRIs. Famously, for all sorts of pain conditions, from knee pain to back pain to headache, it is really challenging to identify radiographic findings, so findings on MRI, X-ray, or other sorts of scans that are related to an individual's pain condition. The data you can see on this slide is from a well-known study of individuals who are totally pain-free, but actually had findings on spinal MRI that you might think would be consistent with a back pain condition. So especially as folks get into their 50s and 60s, many of us have findings like this on MRI. I've recently had occasion to have a lumbar MRI myself. There are plenty of disc bulges, I can tell you that. And they're not always associated with the actual individual experience of pain. Next slide, please. And we have a number of what are considered challenges in the assessment of pain. Unlike lots of other conditions, diabetes, heart disease, cancer, we don't really have objective measures of pain. The gold standard is an individual self-report. People like me are probably not always perfectly accurate or precise when we're self-reporting our experiences, so there can be some discrepancies there. Add to that the fact that pain is quite multidimensional. It has sensory and emotional and cognitive aspects, as well as lots of temporal changes. And it is a real challenge to precisely and quantitatively assess pain. Next slide, please. And so here's an example of some of the challenges of pain assessment. These are some data that I filled in myself for a 24-hour period during a stretch where I was experiencing pain. And so if a healthcare provider asked me, for example, what was your average pain intensity over the last day? You can see how much it varied over that daily timeline. I would have real trouble assigning a single 0 to 10 number to my actual experience of pain intensity, as it varied so much over the course of a day. Next slide, please. Now, we are able to overcome a lot of these challenges, and we can certainly assess pain and get a sense of an individual's experience of their pain. And often, when we assess pain, we divide it into a number of different categories. And so pain is often classified according to its presumed source. There's nociceptive pain that can arise from damage to non-nervous system tissue. This can be your standard pain from something like an injury or a broken bone. Neuropathic pain is pain that's caused by an actual injury to the nervous system. So there are various conditions that can cause neuropathic pain. So neuropathy, multiple sclerosis, or active damage, surgical damage, that sort of thing to nerves counts as neuropathic pain. And then our newest category of pain, nociplastic pain, is pain that essentially arises from sensitization of the pain system. So pain conditions like fibromyalgia would fall into this category. Next slide, please. And those pain classifications allow us to do things like target particular treatments to individuals with particular conditions, which I'll talk about in just a bit. But first, a brief digression to mention that one of the many unpleasant potential experiences of living with chronic pain is the experience of stigma, which I think arises in part from the fact that many chronic pain conditions are invisible, and you're not able to see an individual's experience of pain. There are not objective markers for it. And that can make it very challenging for individuals when they're reporting pain conditions to healthcare providers, family members, or others. This is one of the areas we're working hard on, is destigmatizing chronic pain at the level of healthcare providers as well as at the societal level. We have a long way to go, unfortunately, but we're making steady progress, happily. Next slide, please. I'll also mention that the burden of pain doesn't fall proportionately on everyone. Everyone experiences chronic pain differently. And historically, a number of groups, particularly here in the United States, this is true around the world as well, a number of groups have experienced a disproportionate or disparate burden or impact of pain. In the US, we've known for decades that individuals from Black or African American or other ethnic and racial minority backgrounds experience more acute and chronic pain. They have more trouble getting that pain effectively treated, and they're more burdened and impacted by those pain conditions. We're studying this phenomenon extensively. There have been a number of procedures or systems put into place to try to remedy these disparities. Progress has been, I'll call it steady but slow. We have a long way to go, but we are making progress in that domain. Next slide, please. It is also the case, unfortunately, that many healthcare providers do have some biases when it comes to pain. Okay, to click the advance button. What you can see here in this slide is a classic study that involves healthcare providers. These studies have been done in physicians, nurses, psychologists, other healthcare professionals. The providers estimate the amount of pain that patients are in. And then that graph on the left, what you can see are individuals' pain ratings from 0 to 10 at the beginning and at the end of a treatment program. And what you might be able to tell from that graph is that the pain ratings go down from before to after treatment, which is great. Treatment helps to reduce pain. But at each of those time points, the physicians are rating people's pain as lower than the patients themselves. So healthcare providers tend to underestimate patient's pain. Now, just recognizing these biases is helping us to correct them. Here again is an area where progress has been slower than we'd like, but it's an area we're all working on. And I think these sorts of biases and underestimations of people's pain can be a contributor to the stigma that some patients feel. Again, it will be, I think, a terrific advance for the field when we're able to make even more progress in correcting these biases. Next slide, please. Okay, some considerations and challenges in the management of chronic pain. We can go to the next slide, and I'll spend a few minutes talking about some of the treatments and treatment targets when it comes to chronic pain management. One of the challenges that we face in the field of pain management is that when we're talking about interventions that can be beneficial for individuals, the target isn't just people's pain, because pain impacts so many things, from sleep to recreational activities to physical function to emotional aspects of a person's life. Many of our treatments have to address as many of those important modalities as possible. You can see in that table on the right all of the various areas that patients who are living with chronic pain have indicated are quite important as targets of pain management interventions. Next slide, please. So I can spend a couple of minutes here talking about some of the pain management options. This complicated slide lays out some of the pharmacologic or medication-based treatments for pain. You can see in the table on the left that we have a number of options, from anti-inflammatory medications to antidepressant medications to anticonvulsant medications that were originally studied as treatments for epilepsy. These can be particularly important for neuropathic, nerve-related pain conditions. We have muscle relaxants. We have a variety of topical treatments as well. It is nice that we have all of these available treatments. It is absolutely true that it is rare that such treatments work extremely well for all individuals living with chronic pain. We often have to try a number of them in order to achieve even moderate levels of relief. Luckily, in addition to the pharmacologic treatments, we have a number of non-pharmacologic treatments as well, which I'll talk about in subsequent slides. Okay, to go to the next slide. And so non-pharmacologic treatments, from things like physical therapy to rehabilitation-based interventions, to yoga, to Tai Chi, to psychologist-administered treatments, things like cognitive behavioral therapy and meditation-based treatments that I'll talk about more later. Many of these can be quite beneficial, very rarely curative of chronic pain conditions, but often beneficial for many individuals who are living with chronic pain. Unfortunately, here in the United States, though they're quite effective, they're probably underutilized and less likely to be covered or paid for by insurance programs. That is another area in which we're working hard to move the field forward. Next slide, please. I'll talk a bit about some of these non-pharmacologic treatments. There are a number of them that have been studied and shown to be effective, from things like CBT, which is cognitive behavioral therapy, to meditation or mindfulness-based treatments. ACT is acceptance and commitment therapy. We have other treatments like biofeedback, hypnosis, relaxation-based interventions. Many of these have been shown to be beneficial and to help to reduce pain, to improve sleep, to improve quality of life in patients with all sorts of chronic pain conditions. Some of the things that we need are to increase access to these treatments, which I'll also talk about in some future slides. Next slide, please. And so the overall goal of chronic pain treatment is generally to combine treatment approaches into a biopsychosocially informed multimodal treatment plan, which is quite a mouthful. What that really means is using a number of different treatments. So an individual living with a chronic pain condition may be using several medications. They may be going to physical therapy. They may be using a variety of daily pain self-management approaches to managing their pain. They may be getting acupuncture. And so this combination of 3 or 4 or 5 or 6 different treatments, all of which help a bit, can be really beneficial at helping people to manage these chronic pain conditions that have been so difficult to cure. Next slide, please. I can just touch on briefly the fact that there are often multidisciplinary teams of providers who are managing chronic pain, including physicians, mental health providers, rehabilitation specialists, including physical and occupational therapists, and then other health professionals as well. At the Brigham and Women's Hospital Pain Management Center, there are nurses, acupuncturists, all sorts of other health specialists as well, who combine in these multidisciplinary teams to try to implement the optimal multimodal treatments for individuals living with these chronic pain conditions. Next slide, please. So I can just touch briefly on several non-pharmacologic treatments that you may be familiar with. Cognitive behavioral therapy is an approach that can be delivered by psychologists or nurses or physical therapists. You can advance the slide one more if you don't mind. It's a psychologically directed and informed therapy that helps to do things like train individuals in pain self-management or pain coping skills that I think one of the other speakers will talk more about, as well as to manage some of the cognitive and thinking related aspects of living with chronic pain. It can be a real challenge to mentally organize one's approach to dealing with such a difficult and pervasive chronic pain condition. And those are some of the things that cognitive behavioral therapy implemented by a pain specialist can help people with. Next slide, please. In addition to CBT, we have all sorts of meditation-based treatments. Mindfulness meditation is one. Many of you probably know that mindfulness is generally conceptualized as a sort of non-judgmental awareness of an individual's internal experience as well as the external world. It's been very useful. Training in mindfulness meditation has been very useful for managing chronic pain conditions. We know from a large number of trials that it can help people to reduce their pain intensity and improve their quality of life across all sorts of chronic pain conditions in each of those 3 categories that I mentioned before: nociceptive, neuropathic, as well as nociplastic pain. Next slide, please. It's been a bit of a challenge to get people access to all of these treatments. Lots of the recommendations involve promoting stepped care approaches to pain, whereby when an individual first begins to experience a lasting pain condition, there may be a focus on things like self-care and self-management of that pain. If the condition persists, that may step up to management of pain by a primary care provider. I'll apologize. All of this uses US-based terminology and concepts of healthcare, and so things may be different in various places around the world. After primary care, someone may see a secondary specialist, whether that's a rehabilitation specialist, a surgeon, someone from a background like that. And then there are what are termed tertiary care pain management centers. That is one of the areas in which I work with. The Brigham and Women's Pain Management Center is considered an interdisciplinary tertiary care pain management center where multidisciplinary teams of providers can hopefully provide the most advanced, cutting-edge multimodal pain care. Next slide, please. I'll also mention that there's been a great interest in the remote delivery of all sorts of interventions for pain, from things like cognitive behavioral therapy to physical therapy can be delivered remotely in many contexts now. My colleague Bob Jameson is a pain psychologist at Brigham and Women's. He's developed a smartphone pain app. Many other individuals and groups have as well. These sorts of app-based interventions can do things like monitor pain and pain-related symptoms from sleep and activity to mood and other daily experiences. They can help to connect people with their providers. They can provide cognitive behavioral therapy style reminders for the use of self-management techniques. And these sorts of remote app-based interventions can be a wonderful way to deliver some of these interventions to folks who might not have a chance to access them in person. Next slide, please. And so it's my hope, I think our hope, and you can click one more time if you don't mind, that a lot of the work in this area will result eventually in us being able to personalize and tailor and individualize chronic pain treatments to particular people who present with their own unique chronic pain conditions, and so that we can multimodally target the pains that they're experiencing and optimize the amount of relief and benefit that they get from these sorts of treatments. It's an area that's proven quite a challenge. Many of us are working on this now. It's our hope that in the future, when an individual presents with a chronic pain condition, we'd be able to do a brief assessment and then tailor an optimized treatment to that particular person. Next slide, please, which I think may be the very last slide. I'll just quote Sean Mackey, who is an internationally renowned pain physician and pain scientist out on the west coast of the US. Chronic pain is not all about the body, and it's not all about the brain. It's everything. Target everything. Take back your life. And I think that's a nice reminder that these sorts of multimodal team-based approaches to chronic pain management that address all sorts of aspects of living with chronic pain are likely to be the best possible avenue for managing these complicated conditions. Next slide, please, which I think probably just says thank you on it. And that is exactly what I will do. Thank you so much for your attention and for having me here. It's been a real pleasure talking with you about pain. Thanks very much.
Thank you so much. Can you guys hear me at all? Just put your thumbs up if you can hear me. Can you hear me?
Yes.
No. Oh, okay, good. My computer is acting a little crazy, so I apologize for that. Yolanda, do you want to introduce me before I start?
Yes. Thank you very much for Dr. Edwards' presentation. It was very nice. Our next speaker is also our friend, Penny Cohen. She's a secretary and founding director at World Patient Alliance. She is also founder retired of American Chronic Pain Association. In the 1980s, Penny Cohen founded and became a CEO of the American Chronic Pain Association. She is a very recognized speaker advocating a multidisciplinary approach to pain management and has contributed to numerous books, videos, websites. Penny Cohen has received awards from many organizations, institutions, also from Institute for Public Service, American Pain Association, and American Academy of Pain Medicine. She served as consumer representative for the FDA Anesthetic and Analgesic Drug Products Advisory Committee and co-chair of the National Pain Strategies Public Education and Communication Working Group. She is also an author of Patient or Person Living with Chronic Pain. She also established September as Pain Awareness Month in 2001. The floor is yours, Penny. Thank you.
All right, thank you. Thank you, Yolanda. Hello, everybody. Good morning. Next slide, please. All right, what I'm going to talk about before I talk about any of this is I want to let you know that what I'm going to say is not something I just say because it sounds good. It's because I'm also a person living with pain. I've been living with pain for 50 years now. So, this is something that I actually have implemented all the management skills into my daily life. So the key to what people need for pain is, next, please. Hope and validation. More than anything else, they need to have their pain believed. That's the one thing that I think is critical to so many people. Next slide, please. So the problem is, as pain begins to take over your life, You know, the more it takes over, the more people start talking about their pain, the more they focus on their pain. And it's sort of like these guys walking down this very foggy road. It tends to consume who we are. And pretty soon we just disappear. Who we were before disappears, and we become this chronic pain patient, as so many people refer to us. But we're really still just people. We're people that are living with pain, but there's so much more to us than just our pain. The problem with chronic pain is that it tends to consume people, and they forget everything else about themselves and who they are. So that's one thing that I don't like to hear people referred to as pain patients or chronic pain. I think that's a label that we don't want to hear anymore. Next slide, please. But one of the interesting things about pain is it's not the pain that's the biggest controlling factor. It's the fear of the pain. And the reason for that is we never know when the pain is going to get the worst. It's never at a 10 all the time. It can go up and down. We have good days, we have bad days. And so it's that controlling factor that we don't know. If we do something and it makes it hurt, we're not going to do it anymore. So it's that fear, not knowing when it's going to hit, how bad it's going to fit, that really controls a lot of our actions and our thoughts. Next slide, please. So think about it. Pain can be confusing because there's medical miracles performed every day. I mean, they can give you new hearts, new livers, you know, they can do all these transplants. Our expectation is if we go to our healthcare professionals, they'll be able to eliminate our pain, but they don't. So we get stuck in this big maze of pain. It just sort of takes us from one place to another to another. We get referred here and here and here. And eventually, next slide, please. You know, the problem is, think about it. Can you see pain? Can you measure pain? Can you taste it, smell it? It's invisible. No one can see it. It's so hard to validate that pain. That's why it is so hard when people try to describe it. And we don't always do a very good job of that. I mean, you know, we're trying to, and sometimes we try too hard to explain our pain. So it's invisible, can't see it, it's hard because it's invisible. Next slide, please. So we look to our healthcare providers, right? We look to them because we know that they know how to do this. But the problem is the majority of healthcare professionals have never been trained in pain management. They've been trained in so many things. They're so well educated. They know so much. But when it comes to actually how do you manage pain, they don't know. Most healthcare professionals maybe get at the very most 4 or 5 hours of pain management education in all of the years that they are educated. Interestingly enough, here in the US, veterinarians get 80 hours of pain management. But think about it. That's because animals can't communicate. They can't tell them how bad their pain is. Guess what? We're not much better at that. So what we hear is learn to live with it. Next slide, please. And it makes us want to scream every time we hear it. Just learn to live with it. It's like, okay, so next slide, please. Because when you hear this, this is what it looks like. I have no clue what this is, how to solve it. It's impossible. It's the same with when someone tells you to live with pain. However, if I took a few classes, started with algebra, worked hard, moved up to plane geometry, maybe calculus, even differential equations, I had good teachers and I worked hard, they could teach me how to solve this. It's the same with pain. You can't just tell me to learn to live with it. You have to teach me how to do it. Someone has to teach us how to do it. We don't know. I mean, for so many years, I looked for an answer and I kept looking, and there were none. And I kept hearing, just learn to live with it. And the question, you know, how do I do that? I didn't know how to do it. Next slide, please. And a big part of it is that we have to begin to move from that passive patient looking for them to fix us to become an active participant in our healthcare. And that's a little different than I think a lot of the scenarios are for healthcare. A lot of times we go to the doctor, they do give you a medication, do a surgery, a treatment, and we're pretty good. You know, we don't really have to do anything. When it comes to living with pain, we have to become an active participant. Next slide, please. So one of the things about learning to live with pain is we have to begin to focus on our abilities rather than our disabilities. I know all those years that I did groups, everybody would come in and tell me all the things they can't do. My question to them was always, what can you still do? What are your abilities? We tend to focus on the negative instead of the positive. And believe it or not, our attitude toward what we can do really has an impact on how well we're going to do. So we have to begin to ask ourselves, what can we do? I mean, our abilities as we age are going to change. Our abilities, everybody has disabilities, very different ones, but we all have them. But I want to know, what can you still do? That's part of the success of learning to live with pain. Next slide, please. So even when you have seen the best of the best and done everything possible, there may still be some level of pain. That's unfortunate, but that's a fact. You may never be pain-free again, but you can learn to live with it. If you have the right support, the right direction, you can learn to live with it. And if you take an active role. Next slide, please. You can learn to live with it. Next slide, please. You can live a full life despite the pain. Next slide, please. So the goal of pain management is to improve the quality of your life, increase your function, and reduce your sense of suffering. Nowhere in that does it say get rid of the pain. That's not part of it. But if we can improve our quality of life and increase our function, and yet reduce our sense of suffering, that's not bad. That's not bad at all. Next slide, please. So let's talk about learning to live with that. What are some of the things that we as a person living with pain can actually do? These are the things that I've been applying to my life for the last, since I went through a pain management program. It took me 6 years to get this. So it's been about 45 years since I left the pain program at the Cleveland Clinic. Next slide, please. So the first thing is we have to accept the pain. And I know for so many people I would hear, yeah, if I do that, I'm just going to give up and quit. It doesn't mean that at all. It means, begin to educate yourself, understand what's going on, understand if what your options are. Listen to what your healthcare professional is saying, but accept the fact that for today, you may have pain. That doesn't mean tomorrow. I mean, we never know what medicine is going to come up with. We don't know. But if we begin to accept it and stop looking, I mean, I used to get calls from people that were looking for a surgeon because they had had 25 back surgeries, but they knew the next one was going to help them. Not going to help after all that time. I mean, there's a point. Next slide, please. So the next thing is to actually get involved, to take an active role in our own recovery, to move from that passive patient to begin to become an active participant. That is so very important. Next slide, please. And one of the first places to start is to set your priorities. And that's sort of, interesting. People kind of, what our priorities have to do? But think about it. When pain takes over your life, it begins to consume everything you do. And pretty soon you have all these things, your ability, it waxes, it wanes. You never know when these things you're supposed to do sort of pile up, they pile up, they pile up, this I would tell people to do is to take a bunch of note cards, carry them around. And every time you think about something that you want to do, see something, whether it's at work or at home or when you're out, you just take a note card, write it down. Just keep doing that until you think you've identified all those things that you've always put off. Once you have all those cards, lay them and think about it, stuff. And you just able to eating away because we can't think how start you can just put them in different piles. Absolutely wanted to put those already. So you these are but have at what you need to do, and you have a starting point, because we just become so overwhelmed. Look at all of the things we do. We barely do anything. Next slide, please. So the next slide, please. Is it not moving, or is it my computer?
Penny, you're breaking up a bit as well.
I know I'm sorry, it's my computer. All right, so we have to listen to our bodies. That's one thing that we don't do. We tend to push, push, push. And if we go to the next slide, I'll talk a little more about that. Next slide. Still hear me?
Penny, switch off your camera. Try doing that. Try switching off your camera.
Does that help?
I can still see you if you just switch off your camera.
I did.
Okay. Okay, please continue.
Can you, oh,
Now you're breaking up. Penny, why don't you reconnect? I think we can wait for a minute. If you could get out and come back. So our apologies to everybody. Hopefully she'll be back soon, and then we'll have the remainder of our presentation going well. So just give us a minute.
can you hear me now?
Yes, loud and clear.
Okay, I just switched to my phone. It's my computer. I'm sorry. Oh, I can't see the slides. I need to put my slides up. Hang on. I can't see them on my phone. Okay, so let's talk about goals. So setting realistic goals. Like I said, we have to learn to listen to our bodies. And that's something very few people do, because get this slide down. One of the problems is we have, as I said earlier, we have good days and we have bad days. The problem is on the good days, what we do, because we feel so guilty about not being able to do everything that we're supposed to do, all the things that we want to do, all the things that we should do, that we tend to try to do it all in one day. And we don't listen to our bodies. We don't listen to that first ounce. We don't listen. We push because we want to prove to ourselves and to everyone else we still have it. We still have some value, because the pain takes away a lot of our self-esteem. So we don't listen to our bodies, and we just push, push, push. And so it's really important, after you understand what's really important to you, to begin to set realistic goals. But what you have to do is you have to begin to narrow them down to small, manageable steps. You can't just try to get it all done in one swoop. You can't push through it. So say, you have been sitting, you just got recovered from surgery after another one of those surgeries, and you want to be able to walk in the park again, but you can't do that. So what you have to do is, one step at a time. You have to just sort of walk out to the mailbox, maybe the next week out to the end of the street slowly. I had a lady in my group who would, wanted to bake cookies. And so that was her joy. And so she set her goal for baking chocolate chip cookies. That was her goal for the whole month. But she came to group the next day and said, it doesn't work. I tried to do it because she tried to do it all at once. So we told her, let's do it in small steps. So she mixed the dough one day, and then she put it in small bags, and then she froze the dough. And then the next day, a couple weeks later, she had these little bags. She could bake it all at once. And so she did it one step at a time and was able to accomplish her goal. So that was really important for her to be able to do that. So make sure that the goals are within your ability to make them happen, that you can measure them, that that's something that you can do and it's really important to you. Next slide, please. Oh, I think that's wrong. I'm supposed to be on recognizing your emotion. I mean, on your basic rights. You skipped one. It looks like on my phone. Okay, thank you. Your basic rights. And what does this have to do with your phone? Anything about pain? And as I said earlier, pain takes away our self-esteem, takes away who we are, or it takes away our identity. We need to be able to feel good about ourselves. We need to know that we have the same rights as anybody else. We have, the right to make mistakes, the right to feel good, the right to do less than humanly possible, the right to say no without feeling guilty. These are very important, and they begin to empower us, and empowering us allows us to become more active in our healthcare. Next slide, please. I'm going to rush through some of these. I'm looking at the time. Next slide, please. The next one is recognizing your emotions. And a lot of people say, oh, they just tell me I'm depressed. There's nothing I can do about it. That's not true. It's not that you're just depressed. I mean, who wouldn't be depressed if they were living with pain for so many months, years, decades, all the time? However, our emotions are going to impact how we express our pain and how we feel it. And so we have to begin to recognize our emotions and not let them build up inside of us, because guess what happens? As you begin to build those emotions up, hold them in tight, you're actually increasing stress. And guess what? Stress is going to increase your pain. It's going to tighten your muscles and increase your pain. Next slide, please. So in order to learn to live with it, we have to begin to relax. And Dr. Edwards talked about this a little bit, to listen to your body, to tell it how you want it to feel. And often people will tell me, oh, I can't do it. I can't do it. So what I would tell them is, we had this amazing 5-minute relaxation exercise on our webpage. It was free, and it's still there on the American Chronic Pain Association's website. Before I would play that, and I always played it when I gave talks, I don't have time today, I would ask people in their mind, I wanted them to count from 1 to 25 at the same exact time, simultaneously. Say 1 and 25, say 1 and 8, the same. And we can't do that because we have a one-track mind. So while we're thinking about maybe laying on a nice warm sandy beach, listening to the waves, listening to the birds and the flocking overhead and the palm trees waving, while we're listening to that, we're not thinking about how much our pain is hurting us. So we're not as aware. So we're reducing our sense of suffering. The more we think about our pain, the more we are going to suffer. That is a fact. Next slide, please. And this relaxation, it's going to take a little bit of practice. It's a learned skill, so you have to practice. The next thing is exercise, and this is something that's really hard for people who have lived with pain, because every time we move, it may hurt. And so when they tell us to start exercising, we can't do that. It hurts. But that's because sometimes when we do this, we try to start out too much, too fast. So we have to, again, narrow it down to within our abilities. And sometimes I will talk to people, and we had 18, different stretches that we would always, tell people. We had it in our workbooks that we have. And, we'd say, take it to your doctor, look, because we could never make physical evaluations of anyone. That was something that they had to talk to their healthcare provider about. And we'd tell them to, to see what they could do. And so we'd ask them to do the exercises, but let's start out with, say, leg lifts. Just do 1 every morning before you get out of bed for the first week. Next week, do 2, next week, 3, and slowly increase. So you're not creating any extra pain. You're not, afraid of the exercise. It's not hurting you, just to lift it as far as you can, but you're also increasing, you're creating a routine for exercise. And it's best to do them first thing in the morning, get rid of it. Next slide, please. The next is the outreach. And outreach is sort of where I started after I left the pain program, knowing that for the very first time, going to a pain program, that I wasn't the only person in the world with pain. Because before that, I was so isolated. The more the pain took over my life, the more isolated I became. So it was really important to realize there's other people out there. And if there's other people out there, obviously they need to understand that it's possible to live with pain. And so that's why I started the American Chronic Pain Association. Next slide, please. So just to end very quickly, we always talked about this little car with 4 flat tires, and that's how I would explain a person living with pain. And the expectation is all we need is that one pill, right? One pill, one medicine. The problem is it only puts air in one of our tires. We still have 3 flat tires. We can't go anywhere. So the question is, what else do we need? And for every person, it's going to be different. It's going to be a combination of treatments and therapies that we need in order to get up and get going. It could be physical therapy. It might be some, cognitive CBT. It might be, acupuncture. It might be a support group. It might be nutritional guidance. When you get your tires all filled, it's your job to maintain your car. It's not something that you just, every time you need gas or clean your windshield, you don't go to somebody else to do that. You do that yourself. If something goes wrong, then you take it in for a checkup. It's the same with your health. Your responsibility. You're driving that. You're the driver of that. You are the one that we have empowered, that it's your responsibility to take an active role in the recovery process and work directly with your healthcare professional. Next slide, please. So I want to thank you very much for your attention to this, and we're going to turn this over to Yolanda to introduce Regina, our next speaker.
Hello. So our first speaker is Regina Namata-Kamoga. She is a founding director at World Patient Alliance and also executive director, Community Health and Information Network in Uganda. Her organization is dedicated to empowering individuals living with HIV/AIDS and non-communicable diseases. Regina Kamoga has served on various health advisory committees and boards, including IAPO. Her work focuses on patient rights, particularly for those with HIV/AIDS, TB, malaria, and non-communicable diseases, as well as capacity building for NGOs on governance, policy issues, health literacy, and access. She collaborates with organizations at international, national, and community levels to address patient safety and patient-centered healthcare. Regina, the floor is yours.
Thank you very much, Yolanta, for the introduction. And before I start, I just want to thank Robert and Penny. And Penny has pretty much done part of my presentation. Just like everyone on this webinar, I know that many of us on this webinar have gone through pain at one time or the other. Either mild or severe, it's a journey. And one who has gone through intense pain knows that when you are in pain, for intense pain for 1 minute, it seems like ages, it seems like hours. So having been in pain for over 45 years, I had migraine headache since I was 12 years. And this journey, like Robert and Penny have described, is not a rosy journey. It has not been as easy. And especially when you suffer from pain from right a young age, you feel isolated. You really don't know what's happening. The family members, and especially when you're young, sometimes there's this tendency of thinking, oh, probably you're dodging house chores. It's really difficult to understand, and especially when it is headache, because I know that most people consider headache just a headache. And just imagine in today's webinar, if Penny was to say, oh, Regina is not able to be with us, she's down with a headache. I'm sure many of you would be like, really, a headache? So that's what I've had to go through the 45 years living with pain of migraine headache for so many years. And like you've heard from Robert and Penny, it's life. Like it compromises the quality of your life, and it affects every part of your life, your family, the work, and everything around you. So the whole part of you is impacted. Where in my country, when I was having this headache, especially when I was young, there were a lot of issues. Robert talked about culture. There are also some cultural aspects where some people think it's associated with spiritual. So as we're trying to look for a diagnosis for my headache, because it was looked at just a headache. Initially, it was like, she's probably dodging work. But my parents realized that it wasn't really about dodging work. It was getting more and more serious. Then we had all the different people coming with the different options, probably herbal medicines. It could be spiritual. So in my whole life, I've had to try different treatments, right from the conventional to complementary. I've tried the triptans, the pain relievers, the ergots, and some of these medications have actually sometimes even given me symptoms that are side effects that actually bring a headache as well. So it's a journey that, unless someone has gone through it, is when they can really understand what you're going through. And you have to keep learning at every level. It's not like Penny said, so many of us still don't know how to figure out what's happening to us. It's still, we're living in a haze. You don't know what's going to happen the next day. I'll tell you, you cannot plan your day when you have a migraine headache. Even when the meeting is as important as it can be, you can never plan. So in the process, it affects you at the work level, the family level. In a country where I come from, you lose a very close relative and you don't go for burial, believe me, relationships are affected. It's like, how could she not be present when we are burying so and so? So sometimes, again, like Penny said, we push ourselves too hard because you're like thinking about all the people around you and what they will think if you don't participate in an activity that is very close to your family or friend, and then you end up actually having problems. One time I had to travel 200 kilometers to go and bury. I wasn't feeling well, but it was like, what are they going to think? So I traveled, but I couldn't get back home because the headache got so bad, and I had to stay overnight. And actually, to make matters worse, I had driven myself, so I couldn't bring myself back. So you interface with many, many, many challenges along the way. And the symptoms, you can't, some of them you learn along the way. For instance, I didn't even know migraine with aura until one time I was in a mirror and I was looking at myself. I couldn't see my image. I was wondering what was happening with me. And then after wondering what the problem was, the image is very broad. Then after some time, I see the stars. And then I realize, oh, maybe that is all about migraine with aura. Another time I was driving, and luckily enough, I was in a jam. So there weren't so many cars on the road. There was some kind of jam. So whenever I would, start driving, the car would go off the road and would go like on the side. I would go back to the road, and again it would go back off the road. I didn't know what was happening. Then like 5 minutes later, I started seeing the stars, and I parked on the side. So it's learning every day, and it's like learning on the job, because you don't really know what's happening and what's going to happen next. But along the way, you learn how to live with the pain and how to manage it. And one of the things that I found so crucial in my experience is the family support. Family support is very critical, is very, very important. And not only the family support, but like having a support system right at the family level, as well as your workmates, your friends, to be able to support you. But in order to support you, they need to understand. Because like I said, when someone says I have a headache, you don't really understand what this is all about, because it's dismissed as just a headache. But you need to explain to the people that are around you what's happening, the symptoms, the triggers. Like, for instance, my husband loves a lot of light in the house, but he has learned to adjust, because he has learned that my migraine headaches have sensitivity to light. So he has seen me curled up with ice packs on my head in a very dark room. Just a flicker of light would actually make the situation really worse. And he has seen that, being that we've been together for 30 years. So people need to understand what you're going through to be able to appreciate and even support you better. Your workmates, for instance, they all need to understand your pain and be able to support you, because support is very, very crucial. We need a support system. Like Penny has also said, we need support networks of people that are living with the condition, exchange ideas and learn the coping mechanisms that work. Some of them, Dr. Edwards talked about them, both the conventional and other therapeutic ways. So some of the things that I've done, many of them, Penny has talked about them. The yoga works very well. Dealing with anxiety is another issue. And you know that people with migraine headaches actually have a lot of anxiety. And I didn't realize this until I talked to fellow, people with headaches, and I realized that we all had the anxiety. And, anxiety and stress, almost inseparable, as well as, especially the world that we're living in, working with the work-related stress. So it gets really hard. So supporting each other, being able to see that you manage the stress and anxiety has been one of the things that I've tried to do. That we have good days and bad days, like Penny said. So in those good days, I'll listen to my music, I'll dance, I'll go out swimming, I'll do some meditation, and do all the kinds of things that I can do. So it's a journey. We continue, like we can't let this pain define us, because we know that we can live with it and live a quality of life and be able to be the normal people, and don't compromise, ensure that it does not really compromise the quality of our life as we continue looking for a cure for migraine headache. Thank you very much for listening.
Thank you so much, Regina. That was very insightful, and obviously so many people, I could see some of the chat that were relating to what you said. So thank you very much. Our time is short. Unfortunately, we have no time for discussion. So again, I want to thank our speakers, Dr. Edwards, Regina, for amazing presentations. And hopefully, we'll be able to look at pain into more depth later. This was sort of short. There was so much to say about how to manage pain, understanding pain. So hopefully we will extend this to another webinar at some point in time. So for now, thank you all for joining, and have a great day or evening.
Bye-bye.